Cesarean delivery is defined as a surgical procedure that is performed when a vaginal birth is not possible or safe, and the health and well-being of the mother and/or fetus is compromised. Delivery is made through surgical incisions into the abdominal wall and uterus. Because this is an invasive intervention, informed consent is needed for the procedure, as well as for the analgesia and anesthesia. 25 years ago, less than 1/4 of births were by cesarean, but by 2009, that climbed to an all-time high of 32.9%. During that span, the increase in surgical deliveries grew faster than the rise in population. Women under 25 and over 40 years had the highest rates of incidence. In addition, all gestational ages saw surges in cesareans, but preterm and late preterm deliveries had the highest jump. It is thought this may be related to the large number of multiples being born as a result of in vitro fertilization. There are some conditions that preclude vaginal birth. When they become apparent to the healthcare provider, she will talk with the mother about the need for a surgical delivery. For example, the mother may have had a previous cesarean because of a small pelvis or uterine surgery. She may have a chronic infection such as HIV or active genital herpes. Or she may have an arteriovenous malformation, cardiovascular abnormalities, retinal detachment, or other condition in which bearing down or pushing during vaginal delivery is contraindicated. In addition, there may be physical problems that prevent vaginal birth, such as cephalopelvic disproportion, where the baby's head is too large to fit between the ischial spines, or a primary breach or transverse lie of the fetus. Placenta previa may also necessitate a planned cesarean. Fetal issues may also play a role in the type of delivery. Multiple fetuses, or those with birth defects, such as gastrochesis, hydrocephalus, or spina bifida, may require surgical births. An advantage to a planned cesarean is that the woman can be well prepared intellectually, physically, and emotionally for the procedure. She should be encouraged to practice deep breathing exercises to relax her, ask for music to calm her, and have her partner or coach with her to support her through the surgery. If she desires, she should be able to watch the birth with mirrors. It should be noted here that some mothers who have had previous cesareans may not need another one, and that they can go on to have successful vaginal deliveries with subsequent pregnancies. Unplanned cesarean deliveries are the most frightening for the mother. The American College of Obstetrics and Gynecology, or ACOG, recommends that the procedure be done within 30 minutes of the decision. Reasons for this type of delivery include a labor that is not progressing or stops, or signs of fetal distress such as slow heart rate. A prolapsed cord, in which the cord slips through the vagina where it can be squeezed or flattened during delivery, or a compressed cord, which is looped around the fetus's neck or caught between the baby's head and the mother's pelvis, also necessitate immediate intervention. Mothers with placenta previa or abruption, preeclampsia, eclampsia, or HELLP syndrome may also require emergent surgical deliveries. For years, physicians believed that cesareans were the safest method of delivery for preterm and small babies. However, new research presented at the Society for Maternal Fetal Medicine in early 2012 has shown surgical deliveries are no safer than vaginal deliveries for infants born early or who are small for gestational age. Cesareans were preferred as it was thought that vaginal births might be traumatic for the preemies, putting them at risk for hemorrhages and other complications. But the studies have confirmed that these babies were at no higher risk for subdural hematomas, seizures, or sepsis than infants born vaginally. In addition, it was noted that babies born surgically were 30% more likely to develop respiratory distress syndrome, as they lost the advantage of fluids being forced out of their lungs during the descent through the birth canal. Statistics also suggest that cesareans were often performed when the fetuses were not growing fast enough in utero. Conventional wisdom was to deliver the babies early and manage them in neonatal intensive care units where they could gain weight and thrive. This study revealed that outcomes were better for the infants with gestational periods of 40 rather than 37 or 38 weeks. Infants born early are prone to respiratory problems secondary to immature lungs, as well as feeding difficulties, maintaining body temperature, and jaundice. They may also be at risk for learning, intellectual, sensory, or physical disabilities, as the last few weeks of pregnancy are vital for normal development. Elective cesarean deliveries are sometimes requested by mothers who want to schedule their baby's date of birth, who fear labor and delivery, think cesareans are safer than vaginal births, or just want what they think is the easy way out. Cesareans are major abdominal surgery with risks of infection, hemorrhage, organ injury, and anesthesia complications for the woman. The babies may also be compromised as they are usually delivered early. Therefore, these elective procedures should be carefully thought out and discussed by the parents and their healthcare professionals. A cesarean delivery is a team effort. Members are an obstetrician, an anesthesiologist, a surgical nurse, and the coach to care for the mother. A neonatologist or pediatrician, a neonatal nurse, and potentially a respiratory therapist may be needed for the baby. The professional group must be highly trained and experienced and have completed the American Heart Association's neonatal resuscitation program, so that if the newborn needs emergent care, it can quickly and safely be provided. In addition, the nurses must assure that the delivery room is well equipped. This includes having a warmer ready and resuscitation equipment available in sizes that are appropriate for the smallest premature infant to the large for gestational age baby. Suction catheters, umbilical catheters, oxygen delivery systems, self-inflating resuscitation bags, endotracheal tubes, intravenous catheters, medications such as naloxone and epinephrine, and fluids must be readily at hand. Also, the surgical nurse must do a sponge and equipment count of all the items on the trays to be used during the procedure before it begins. When the woman comes into the hospital, she should be oriented to her room and told exactly what to expect. The nurse should then take a history by asking questions about the mother's general health and this pregnancy in particular, noting any problems or complications that arose during this period, as well as why the cesarean is needed. In addition, information should be obtained about any prescribed or over-the-counter medications taken, if any herbal supplements, recreational drugs, alcohol, or tobacco were used, or if the mother were a victim of domestic violence or abuse. Because this is a surgical procedure, the nurse should also ask the mother when and what she last ate. The woman should not have had a regular meal for 8 hours, had a light meal for 6 hours, or fluids for 2 hours. The mother then should be prepped for the procedure. She will get into a gown and have her vital signs taken. An IV will need to be started. If possible, the nurse should draw blood at the same time for CBC and type and cross-match. Clotting times and fibrinogen may be needed as well if the mother has a history of bleeding problems. After the labs are drawn, a crystalloid solution will be hung. If an epidural is planned, a bolus of 1 liter can be started. If spinal anesthesia is to be utilized, 1.5 to 2 liters of fluid should be infused. The anesthesiologist can come in at this point and talk with the mother as well as get her consent for pain control. An epidural may be considered. Placement of the catheter is higher than for a vaginal delivery, so that dermatomes T4 through S5 are affected by the analgesia and anesthesia administered. Contraindications for this type of block include uncorrected hypovolemia, coagulation defects, systemic infection, or allergy to the drugs used. The mother will be placed in one of 2 positions for insertion of the catheter, either side-lying or sitting with her neck and head flexed so that the space between the vertebrae is increased. A test dose of medication is administered, which takes 20 to 40 minutes to become effective. If there are no problems, the continuous infusion can be started. At that point, the mother's vital signs will need to be watched closely. They should be recorded every 2 to 3 minutes for the first 15 minutes, then every 5 to 10 minutes for the next 30. Blood pressure should be monitored as there is a risk of hypotension with this type of regional anesthesia. Other side effects are pruritus, nausea and vomiting, bladder distension, back soreness, and catheter migration. At this time, an indwelling urinary catheter can be placed. Spinal anesthesia is another option. Medication is delivered in a similar fashion to the epidural. However, it is injected directly into the dural sac. The main side effects of a spinal are headache and hypotension. In addition to the anesthesia and analgesics, mothers should also receive preoperative antibiotic therapy, usually a cephalosporin, to avoid endometritis and other infections. A cardiopulmonary monitor is attached so her vital signs can be closely observed. Her abdomen is cleaned with an antibacterial solution. Shaving is not done, but clipping may be considered depending on the type of incision. A grounding pad is then attached to her thigh to prevent electrical mishap or fire when cautery is used. Oxygen should be administered by nasal cannula or mask. According to the new guidelines from ACOG, thromboembolism prophylaxis is recommended at the time of delivery. Therefore, inflatable compression devices should be placed on the mother's legs and remain until she is able to walk after delivery. The woman is then placed into a supine position with a wedge under her right hip to keep pressure off the great vessels, and a sterile screen or drape is placed in front of her chest. All of this prep time in the OR should take about 15 minutes. Once the obstetrician is certain the area is anesthetized, he can make the incision. For non-emergent cesareans, horizontal incisions at the first skin crease, just below the pubic hairline, are utilized. The uterine incision can be either horizontal or vertical, the latter of which may be associated with uterine rupture during subsequent pregnancies. The baby is then removed from the uterus. After the cord is clamped and cut by the physician, the infant is handed to the neonatologist, pediatrician, or neonatal nurse for evaluation. If the neonate is stable, he or she is given to the coach and shown to the mother. While this is occurring, the physician removes the placenta. Before suturing of the uterus and abdomen, the surgical nurse does a repeat sponge and equipment count. After the procedure is completed, the mother's vital signs are monitored, her abdomen palpated to determine if the uterus is contracted, and peripads observed to estimate blood loss. An emergency cesarean delivery must be performed when time is of the essence to preserve the well-being of life of the mother and/or fetus. There may be little time to emotionally prepare the mother for the surgery, so staff must do its best to be calm and supportive while getting her ready for the birth. In fact, it is recommended that the procedure begin within 3 minutes of the mother entering the surgical suite. An IV should be started if one is not already running. Any necessary labs should be drawn at the same time and sent to the lab stat. If an epidural has not been previously placed, the anesthesiologist and obstetrician will quickly have to determine the type of pain management for the procedure. Initiation of an epidural or spinal is not appropriate in an emergent situation, as the medications are not effective until at least 20 minutes after their administration. Therefore, there are 2 options the physicians can consider. One is a subarachnoid block. The woman is placed in the same position as for the epidural. After the anesthesiologist numbs the area, he will inject anesthetics directly into the subarachnoid space. This will produce an immediate loss of sensation and motor function below the injection site. However, the effects are self-limiting, so it is critical that the mother be watched closely for any signs of pain. The woman's vital signs must be frequently monitored, as hypotension and bradycardia are common. The mother should also be given supplemental oxygen at 2 to 4 liters per minute. If the mother or baby's condition warrants immediate birth, there will not be time for regional anesthesia to be delivered. Therefore, general anesthesia is the only option, as it can be provided quickly and it has a rapid onset. The problem with this technique is that the medications cross the placenta and the baby will also be sedated. After the drugs have been administered, the mother's vital signs must be closely watched and recorded every 5 minutes by the anesthesiologist. If there is no time to perform a surgical scrub of the woman's abdomen, povidone iodine should simply be poured over her belly. The obstetrician will then make a classical vertical incision through the skin from umbilicus or to the pubic hairline and then into the uterus. The baby will be quickly removed and given to the neonatologist or pediatrician for immediate assessment and stabilization as needed. After the placenta has been removed and the sponge and equipment count is complete, the physician will begin the suturing process. If the mother were given regional anesthesia and the infant is stable, she will be able to briefly see and hold him or her before leaving for the PACU. The baby will then go to the appropriate nursery for more definitive assessment. If she were given general anesthesia and the infant is stable, her coach will be able to hold the baby for a few minutes. At this point, the mother will go to the PACU for recovery, and the baby will be transferred to the nursery. Non-elective cesareans can be a frightening and emotionally draining time for mothers and their partners. Therefore, staff working with them should not only assure that the families are getting excellent physical care, but the psychosocial support as well. Nurses and physicians can assure that coaches remain at the bedside during prep and even the deliveries. The healthcare team should also provide care in a calm manner, even in the face of emergency, as any frenzy will exacerbate the woman's unease and ultimately affect her vital signs, making her tachycardic and even hypertensive. In the delivery room, if the mother is awake and alert, she should be offered mirrors to watch the birth. And if the baby is stable, he or she should be swaddled and given to the mother and coach to hold as soon as possible. In essence, the goal should be to make this experience a positive one for the mother and her partner.